Hey everybody, welcome back to Life on Purpose. My name is Josh Hampton. I'm a peer support specialist with Sunrise. I am one of your hosts.
I'm Kevin Mahoney. I'm the other host. You're really loud today.
Am I? Well, I was asked to speak up.
I know.
So we both work for Sunrise. This broadcast is brought to you in part by Sunrise Community and Recovery and Wellness and Asheville FM. A little bit about Sunrise. We are a recovery and wellness community center. We're a nonprofit staffed entirely by certified peer support specialists who utilize their lived experience to provide authentic peer support, resource navigation, and education to individuals struggling with trauma that often leads to substance use and mental health issues. You can find out more at www.sunriseinasheville.org. Please remember that the views and opinions expressed on this show are not those of Sunrise Community for Recovery and Wellness or Appalachian Mountain Health. Thank you. So this is Life on Purpose, and we have a very special guest with us today. Would you like to introduce our guest, Kevin?
I'll introduce the guests introducing themselves.
For me?
Yeah.
That's not how this works.
Dang it. Okay, it'll come back to me as soon as we get done recording.
Okay.
I'll call you. Here's Summer Hettinger. I've known Summer for a long time in community health, attached to Dale Fell Clinic, Appalachian Health. What did it used to be?
Oh my goodness, there's been so many names now.
The progenitor of that.
So yes, it was Delfell Health Center, which
Yep.
people still know us as,
That's what
right?
I still call it that. Yeah.
And a lot of people still do. Then it was Appalachian Mountain Health Community Health Services, and then we decided that was a bit long, and so now it's Appalachian Mountain Health, and so the Del Fell Center is the Asheville Health Center now.
Okay.
So here's what I do. I say, I work at Appalachian Mountain Health. Remember the Del Fell Center? We call that the Asheville Center now. So it actually takes longer.
But one time.
But some people call it Asheville Center now, so that's the hope movement.
Is Dr. Dowling still there?
Yes.
Oh.
Yes, the legend.
The legend.
Yes.
Also, Dr. Steve Crane, the original OG.
That is the OG, yeah.
I think he was in Hendersonville, and now I've lost track of him again. And another genius idea person that actually makes things happen. Anyway, we're glad Summer's here because somebody had the idea. We've talked about trauma. We've had several shows about the fallout from Helene. We had shows about self-care. We've had some community players and actors, and then Jody Ford came up with the idea about our media director of, why not reach out to Dale Fell, Asheville Center. I said, yeah, I know somebody there. And here we are. So my questions, I want to talk about nurse practitioning anyway, because I've read several articles in the last year in medical journals about it's such an emerging that the nurse practitioner do it. Also, let's blame the nurse practitioner because something goes wrong in the ED. It just seems like, and again, we get that from as being peer support. It's like, let the peer support do it. Peer support do it until no. Find it, and I like to explore the scope and lane of your practices and what community health, at least around here, looks like, and maybe some education and preventative measures for the community and whatever we can cram into 50 minutes.
Yeah.
Cool. You want to tell us a little bit about your background before we actually launch this?
So I started as an RN at Mission Health, and I was there for 12 years as an ICU nurse. Before that, I kind of dabbled in Haywood County and did the ICU there and cardiac rehab, pulmonary rehab, just kind of got my feel and really wanted to do intensive care unit. So I went to Mission and was there. And then when I was there, I volunteered at ABCCM, their medical ministry.
On Livingston.
Yes, on Livingston. And I fell in love with community health.
Aww.
I didn't know much about it. I went from RN school directly inpatient, which a lot of nurses do. Had a rotation in school, but it was only at the health department. So I didn't really know what else was out there. So when I started volunteering there on Tuesdays, I was like, oh my gosh, I love this so much. And there was a really wonderful nurse and NP there at the time that was they were nudging me. They were like, go back to school, do it. You should do it. Do it while you're still happy. And so I did it, and I actually ended up doing a residency, like a summertime internship residency at Minnie Jones. And so then I got even more of a glimpse of what community medicine could be at an FQHC. And life happened too, had a baby, and Appalachian Mountain Health was getting its start. And had a professor that started working there, and she recruited me because she knew how much I loved community medicine. And at that time, there was a very small clinic downstairs of the Vanderbilt Apartments. Do you guys remember that old radio station that was there?
Yeah.
So we had a center that was in their basement.
Wow.
And so when I started that clinic, and then in the rescue mission, we have a clinic, and then at the Asheville Center. So, that's how I started. So I've been there about 8 years now. So I was a fresh nurse practitioner when I started. Dr. Dowling was my supervising physician and still is, and my mentor. And then I started doing more like community outreach at the rescue mission. And then this mobile unit came alive about 2 years ago.
You probably have a little bit of pull after 8 years, right? Pretty influential.
Yeah, I'm one of the long-termers now that's there. So it's Dr. Dowling and I and a few other faces that you would remember. But there's, like in healthcare, there's a lot of turnover. So, yeah.
It is a lot of turnover. This landscape looks vastly different 10 years later.
Yeah.
It's amazing.
In a lot of the spaces, like a lot of the community partners too. So.
Where'd you get your training at?
Western Carolina.
Okay, that's and then what? What do you take to get to?
So I did my bachelor's degree, was a RN working in the field for a while, and then I went back for my master's there. And now a lot of NP programs are doctorate programs, but I did it long enough ago now that I'm good. I don't have to go back.
No?
Yeah.
Cool.
Yeah.
What's the difference between like family medicine and community medicine?
That's a great question. There's not a degree for community medicine.
Should there be?
That's a great question.
Okay.
I feel like there should be, it's a lot of it's experience, I feel like, right? Like a lot of the community stuff that we do, it takes time to make the connections and relationship. And I feel like some of that you can't learn. Like you can't teach somebody that. You can learn it, I guess, but you can't teach somebody. So I think a lot of it's experience based. I probably could have had a few more rotations of like, hey, you might like this, and like maybe pull me in a little bit sooner. But I think also just the experience of doing what I did do made me better at what I'm doing now, And the relationships, like we've known each other for a really long time.
Yeah.
And so when I got the email that was like, and Kevin, and I was like, oh my gosh, that's so cool. Yeah.
You better tell what GOAT means.
The greatest of all time.
Not
GOAT.
That's not. But I appreciate the compliment.
Yeah.
I know. And I tell folks in peer training, the ones who are just starting out, saying, this job isn't for everybody, and I don't think your job is for everybody either.
I agree. We just recently hired a new medical assistant, and she has no experience doing medical assistant work. She's been a pharmacy tech, and then she came out and saw us operating at one of our sites at Salvation Army, and she saw like the tent, the van, the kind of chaotic nature of what we're doing, and she said, oh my gosh, I love this. And I was like, I think you're the right person for the job, because there's some of the skills that you can teach, and then there's some things that are just in your heart. And I think some of that's probably the same for peer support and depending on which location and where that peer might fit better in an office space versus out in the field versus, all the different spaces that y'all can be. I feel like that's exactly how nurse practicing is too. There's people that are like, they just like the office better. It's more predictable and that sort of thing. And then what we do is very unpredictable. You have to be flexible. You're meeting people where they're at. If someone's late for an appointment,
do you guys use peers still?
that's a great question. So we had a lot of peers at one time, and then there was a shift.
I know.
I believe it was around COVID time where a lot of things shifted, and had a lot of people turn over at that time, and so we now have, they're called community resource advocates. And so it's not someone that has as much of a lived experience, but it's someone that's a resource. And I think what we found is that when we partner outside of AMH, is the shortened version.
Yeah,
Mountain
we'll
Health.
call it that.
AMH, that there's just a little bit more continuity there. And so we're using the community resource advocates to help link to services like signing up for Medicaid, housing, logistical type of programs, and then using you guys and other services.
You guys being Sunrise.
You guys, yeah, Sunrise.
Use guys.
Use guys over here.
So the community resource advocates, would that be something? You said those are outside, like y'all are outsourcing those, or they're
no, they're hired internally.
Okay.
With us, yeah. And so we always have someone like on site with us on mobile, and then at each center we have community resources.
I got you.
Yeah.
Would that be somebody that anyone in the community might be able to reach out to for a resource? Like if they just were looking for a resource for housing, or
they
sign up on
can.
Medicaid?
They can. We primarily we work with our patients that come in too.
Right.
So we would obviously ask them if they have a primary care, if they're interested, that sort of thing.
Okay.
Yeah.
That's not your main income, though, right? You take insurance. I don't remember the billing system.
Yeah, we yes.
It's pretty open.
Take insurance. We have a sliding scale.
Okay.
It's a federally qualified health center, so we won't.
There you go. So you get matching
we don't
funds.
turn you away.
Yeah.
Yeah.
That's supposed to, right?
Yeah.
So office versus kind of chaotic environment. What else is different between office medicine, family medicine there, and medicine in the field?
Meeting someone on their own turf, in their
Literally.
own time, and however they present. So if someone presents and they're ready, for example, if they're ready to do treatment for opioid use disorder, and they come after they've used, we will still engage that person, see where they're at, see what we can do that day, see what makes sense for them. And I think that can look different in the office. Is someone going to walk through the door? Probably not. You know what I mean? Are they going to be able to fill out the paperwork and do the things that are expected in an office? It's different. And what we can do is we can meet them where they're at. We can sit in the grass and hang out with them. We have a behavioral health specialist with us that can start a relationship building and connection. And they don't have to fill out paperwork for me. I can ask them questions and type it in. And I think in the office there's providers that can do that too, but the flow is different.
Yeah.
There's providers that would do that. There's spaces where they would do that, but it's a different flow in the office. So
You've talked about chaos and a little bit about structure. Where do you feel more at home? Does chaos feel more calming to you than?
I kind of like a little bit of both.
Yeah.
I mean, if we have a really chaotic day, it does feel good to go back to a space that I can be now let me, because I have to chart it too, right? So as much as I can do the sort of flexible, adaptable schedule, I still have to get it on paper. I have to send a medicine. I have to make sure that people are signing a consent for treatment. There's still things that we have to make sure happen. We just kind of do it differently. Yeah. We'll sit with someone and hey, you should sign this. And explain it differently instead of here's a clipboard of 8 pages, and some people can do that.
Yeah, or your consents and RIs.
Yeah, and some people don't, and some people don't want to sign a consent because they have, it feels suspicious.
What am I signing?
Yeah, and there's
that.
some big words on there that are ooh, I'm not sure. Yeah.
What services do you guys provide directly out in the field?
So we're an integrated primary care.
Okay.
So that means we can do primary care and behavioral health. Often we'll do co-visits together, and then if they need more robust primary care, we'll sort of come over here, and then more robust therapy, then they can like meet back with that person. We have the community resource advocate with us, and then we also have pharmacy consult available, women's health, and dental.
Wow.
They're not all with us on site, but we have the like connection in the community. So
Yeah, that's awesome.
yeah, it's really great to be able to see, let's say like a female patient, get them in for primary care, maybe start MAT if they need it, therapy, and then when they're ready, have a pap smear. Do some preventative medicine when that person is ready. Because the van's not a perfect environment for a pap smear. So
Yeah, a little crowded in there.
Yeah.
yeah, but we can do labs too, which is cool. So we can do injections on the van. So we're a certified site, and so that means that we can do injectables. So like long-acting antipsychotics, long-acting buprenorphine, Vivitrol. So we're not dispensing, but we are administering medication.
What's the difference?
So we're not a pharmacy.
Okay.
So pharmacies dispense. Our pharmacy dispenses to our Asheville site, and then we can give the injection. We can administer it. So that allows us
as
to
an
give
NP, you can prescribe, but you'd have to check with an attending or check back with a physician.
I can do it. Yep.
Okay.
Yep.
What kind of areas do you provide service for? Like in and around? Is it housing?
Like where our sites are.
Yeah.
So on Mondays we're at Transformation Village. Tuesdays we're at Compass Point. Wednesdays we're at Salvation Army, and then Thursdays we're in public housing. So specifically PVA and Aston Towers.
Okay.
And then
I thought I saw you over by not you, but the van.
Yeah.
I was like, that's an Appalachian van. Battery. Not battery. That's
Bartlett.
Bartlett.
Bartlett Arms.
Yep.
So Bartlett Arms was on our rotation, and we found after about 18 months of being there just wasn't as much engagement from the community that lived there. A lot of people were coming from outside of Bartlett Arms to see us.
That was going to be my next question.
Go ahead and ask that. I was going to too.
Well, so like, I guess outside of TRV or Compass Point, at the other locations, you don't have to be like a resident or locally in that area.
You're
You
just
can
there.
come from anywhere.
No, yeah, exactly.
you.
So
Okay.
we'll see you no matter where you live. If it makes sense to have you then follow up in the office, then we do that. So
Okay.
it's a nice way to like get an appointment in the community, and then we can get you a transfer of care into our brick and mortar. So we go once a month to RHA, Pure Living Room.
Cool.
And that's been a really nice space for some of the recovery spaces to bring patients. So First at Blue Ridge, for example, will bring a van of people when we're there that need connection to primary care, that don't have anything in town. And so we'll try to see those folks, and then they're sort of in a more stable space, so then we'll get them a transfer of care into brick and mortar. Which is nice. And then they also know about Pure Living Room. They know about services. You know, health department team usually will co-locate with us, so they can check for like vaccine records and get them what they need for rapid testing, like they do here in the Sunrise.
What are the most, in an uncommon, chaotic situation, what are the most common things you see out as health issues?
We see a lot of wounds out in the
like
field.
abscesses?
Yeah, we see a lot of wounds, a lot of behavioral health needs, a lot of refills for meds. We do chronic care as well. There's a lot of folks that are unhoused that have diabetes and need help managing that. A lot of opioid use disorder.
How about my thought about medications? Dang it, I lost my train of thought.
Medications can be tricky, right? So we're sending in medications, and then there's co-pays. Or our pharmacy's great, but it's out on Lester Highway. So bus route, thinking through like bus routes, where they can go. Do they have a case manager? Can someone help? Peer support often is something that people are like, oh, let me phone my peer or caseworker, and they're going to help me out. Or there's funds at some place, right? Someone can help me get this somehow. And So there's a lot of navigating.
So say a person has their behavioral health and Mahoney psychiatry. You got them for everything else. How do you coordinate?
We sign a release, and then there's some point people that I have at different locations. Like I know someone on Mahoney Psych that I can call and say, hey, I just sent this ROI, and so it goes back to the relationships.
It's all about relationship.
It is, and a lot of the folks that we see, there's services at AHO that Mahoney is there a certain day a week, and so if we're seeing them and they're seeing them, we have to be careful.
Yeah.
Right? And so we have communication now.
Oh yeah.
That's great. So like we'll talk to Mahoney, they'll talk to us, and we'll say like, hey, there's this ROI, and we both don't need to see the same person, but we need to help that person, go into the right direction.
Sure.
Hey, we can see you today for this like acute thing, but Summer's going to be at Compass Point on Tuesday. Don't you live there? Oh, go there. And the same with me. If I see someone as a Mahoney patient and they just like pop up and need something, then I'll say, if you've been there for 6 years, there's no reason to continue to see me if it doesn't make sense. If it makes sense, it's got to make sense for the person. So, yeah.
Are there any specific health disparities or social determinants of health that you tend to see more than other things? And I use the 8 social determinants. There's 13 or 16, but it's all the things that make life a little easier, like education and employment and spiritual health, physical health, mental health, transportation, jobs.
Yeah, I would say, transportation, housing, transportation, housing, behavioral health needs, unmet behavioral health needs, and access to medication that's life-saving. So I think those were the 4 big ones for me.
What's your elevator / I said, what have you been most proud of up to this point? Which is your bragging card? What do you pull out of your wallet as far as a case, like your success story? I have success stories. So
right, yeah.
Keep them pretty close, just in case somebody wants to talk about them.
Yeah.
Somebody who came in with nothing.
I get these like flashes of people's faces
I know.
right now, and
probably daily.
Yeah. I just walked over here from Compass Point.
Okay.
And one of the people that now has moved on from there.
Yeah.
Is a face that I always think of. And when I first met this person, I was working at the Rescue Mission Shelter Clinic, the Maze Care Center, and she was laying outside of the building. And so it took numerous encounters to engage, and then finally she came in, and then she went from, that space to then needing respite, to then getting into Compass Point, to then getting into a scattered housing site. And that's someone that is that's always been drilled into me. She kept fighting for it, and she did it with support around her, and housing, right?
Yeah, but the other thing I say to people that are just starting out in the peer job is pick your levels of success. Whatever bar you're using as your measuring stick. Don't be too rough on yourself. My success is keeping people alive, either for somebody else to maybe help further down the line, or they're just alive, and I see them 10 years later. They may be in Compass Point, which is, I'm so proud of that place for what it's done to folks that I served that were camping and on the street.
Yes. Well, and to that, you can probably see this like I do. When I first started there, seeing the folks, it's like I already knew them.
Yeah.
And then they were here. And now, it's been a year and a half, 2 years maybe, year and a half. And I can see the residents that are there that now they've had housing for a while, and they've had opportunity for integrated primary care, and some have really engaged in it, and you can see some significant changes in their life.
Yeah.
It's really cool to see it from start to
Put a roof over somebody's head.
Yeah.
Give them something to get out of bed for in the morning or wherever they're crashing.
Yeah.
The landscape now is compared to the landscape 12 years ago. Because what are some changes?
I feel like there's better access. Better
more
access
of you
to
around,
care.
yeah.
There's so many. It seems like there's so many more like community partners. There's more conversations happening. There's more collaboration. I feel like we're not working in silos as much anymore. I think we can still improve on
my
a lot
favorite
of
word.
That.
Yep.
Silos?
Yeah.
Oh, I know, it's a good
siloed.
one. Oh, less siloed.
And rubric.
Oh, that's a good one.
Rubric.
Oh, yes, that sounds very good. Let me check that off my rubric. Yeah, I feel like that's certainly improved things. And there's more mobile.
Yeah, there's vans.
Yeah.
There's vans everywhere. I'm like,
There's some
there's
vans.
so-and-so, there's so-and-so.
Yeah.
That's such a big deal.
It
It's
really
a big
Be able
deal.
to get out to, underserved areas, folks that may not be able to travel to
Yeah.
a brick and mortar location.
The comfort that patients have expressed with our mobile it's so
How many mobile units do you have?
we have one.
Okay.
And we are like we're so spilling over that we are actually expecting, I'm so excited to say we're expecting a larger unit, and it's coming at the end of July.
Wow.
And we're running out of, you guys have seen it, it's like it's a van that it's, slides open and it has one exam, enough room for like 3 people to sit kind of close. And the RV that we're getting is a 2 exam room.
Wow.
And then we will have this other one, and so our program is expanding because we're so busy everywhere we go. We actually cannot see everyone that comes.
Wow.
Yeah.
Who are your go-tos? Like I used to refer people your way all the time because I knew the people there and I knew the practitioners. I'm like, they're all dependable.
Yeah.
Who do you go to when you say if you couldn't help somebody, who do you find yourself referring out to?
Oh, well, that's a good question.
There might be a lot. I mean, maybe CCM.
Sure. Yeah, I think it just depends on the need. It depends on the need and where they live. Because it has to make sense. We used to go to oh gosh, I'm forgetting the name. The Shiloh Community Center. And what we found is that there were some like really lovely people there, and we connected with a lot of them, but they were already connected to Mahak. And I was like, what are we doing in this space? It doesn't make sense for us to be here. So we shifted, and those folks needed to stay with Mahak. They were like right down the road. They'd been there forever. They had access to them. So I think it just depends on, location, where they are, what their needs are, what makes sense for them.
What's the ongoing challenge with an already underserved population of helping them? I mean, you fix the health system, Summer. I'm not putting you on the spot.
That's a really big question.
I know.
Just a real simple question to answer.
Yeah.
Take your time.
Oof.
Money?
Funding. Navigating insurance. Getting things covered. All these new plans popping up and figuring out, which medication that would be best for the patient, but this plan doesn't cover that one, and so then the patient goes to the pharmacy and finds out it's not covered, and then, so there's like all these sort of loopholes and things you have to go through to get a need met, and that can be really deterring for the patient, right? To like keep chasing down.
To the point of like, the hell with this, I'm not gonna
so
do
we're
it.
like coming to you and trying to make things easier. There's peer supports that are trying to like support them and get them here and there and everywhere and talk, and then we get to the conclusion. Here's this medicine that might be really helpful, and now we can't get it. So that can be hard. I'm sure you guys have worked with folks that you get to the CT scan that was scheduled, and then it's not approved, and so they've spent their day, doing it. You spent your day doing it. Now we have to reschedule. Now
That's really discouraging.
It's discouraging. Yeah. So.
And let me phrase this politically correctly. a lot of times when I'm assisting people, or have been, and we would have to maybe visit the emergency department, and I've overheard this with my own ears about, oh, it's those people again. Oh, it's you, frequent flyer, which I won't use anymore as a term, but it's still used. How do you combat stigma in the medical community with the folks that you serve, knowing them and knowing them as people, and not objects?
Yeah.
What do you say to people who say addict and alk, and in your field, our field? How do you educate them gently?
That's a great question. I feel like now the community that I work with and I work alongside, we're pretty good at that.
Yeah.
Like, right? We don't use terms that are like that.
That you have to correct.
Right. I don't have to correct it. Right. So often what I find myself doing is I'm like correcting patients to rethink how they label themselves.
Are you sure you're just an alk? Are you sure you're just an addict? And I've had those convos too. I'm like, you're more than that. You're a mom, you're a dad, you're a parent.
I think it can start with some of that, but then also, we have things like, flyers on our walls and things like that of ways to rethink how to say things. And it's great at Mission right now is that they have addiction medicine fellows that are there, and it's new. And I think that their impact is going to be really great for the hospital setting. I had a phone call today from one of those people that wanted to collaborate on a patient that they're seeing, and the approach that they have is more of the approach that we would take with somebody. And so I do think that is going to reshape some things and help to spread that, diffuse that stigma that's out there. I think it's going to take some time, but there are people. There's the helpers out there that are doing the work and trying hard. And
so I had two residents. They were started as residents. I knew them first years, and they would come to peer support to get the community health bit. And you can feel that when somebody gets it. You just said you have your community's health sweet spot. Yeah. You know it resonates. Right. And I said, these folks are the real deal. Yeah. And they stayed with it, got into it, more of addiction stuff, addiction fellows. Yeah. Mission hired two of them as...
I think that's what I'm talking about.
I don't want to say names. Nobody. But their heart's in it so much that... Yes. I said, there's going to need only two of you for all of Mission Hospital. Right. Okay.
It's a start.
It's a start.
I feel like it's a start, and I've found that when they are consultant, the care is improved. So
they've had 4 years of this already, 3 years of it, and then again, when they went on, I said, take care of yourself. Please, please, please don't hit compassion fatigue or burn out, even worse. Yeah. Another thing that I show younger peers is it's a Gabor Mate video talks about the medical community being traumaphobic in terms of when the underlying root of an addictive situation is trauma-based. He says that medical schools, maybe they're doing a different job of it now, but they didn't talk about trauma and ACEs and childhood stuff. Yeah. Now more of that's seeping in and more peer support. Yeah. Do you see that kind of change filtering up to your level now?
I think it's seeping in. I think that's a great term. I think that I see it often integrated into what we're doing because of where I work and because we work so closely with our behavioral health colleagues, and they're so in tune with it. And so I think I have a little advantage of that with the group that I'm specifically working with. And we have really great behavioral health clinicians that trauma is such a big thing with the folks that we're reaching. I know there's a big push for, mental health first aid classes and resiliency training and those things. And I know our organization focuses on that. So, and just not at the provider level too, but like front desk, NA,
cultural awareness training,
everywhere. Yeah, because it's not just the provider that's making the touch on the patient, it's everyone in the office. So I think that piece alone is super important for organizations.
and like in a regular, like a family medicine clinic, you've got 40 minutes, probably max, that's your appointment length. What are you going to do about childhood trauma in 40 minutes?
Right.
This is where the traumaphobic part comes in. He goes, we don't have time. We want to fix it. We have a problem.
Right.
So Western medicine.
Mm-hmm.
What's your take on Western medicine in terms of a philosophy? And I talk a lot about, I know.
I love it.
Being reactive rather than
Sure.
preventative. How much money
Right.
could we really save or make if we would just address things from the very beginning and not send it down the line or not silo it, or I don't know, I'll leave it for you to answer.
Medicine.
Well,
and
again,
integration.
reactive versus preventative. I guess maybe go from there.
Yeah. It's a great question. I feel like, yes, I love the philosophy of Western medicine and preventative. I think that our system is set up to where that makes it really difficult to do. And oftentimes I'm already working with someone that I'm having to have some reaction to the problem that's presented. And so I find myself integrating that into my practice. So there is some reaction based on the problem, and then we work towards that preventative stuff.
Okay.
Yeah.
Have you ever had to work with a patient that had maybe a really different philosophy of health, whether it's Ayurvedic or it's like, well, I don't, and they don't like Western medicine?
Absolutely.
Have you run into that where you've had to like mitigate culturally what the medical
Absolutely.
needs
Yeah.
are? Okay.
Yeah. I can think of a patient right now that that would benefit from some more medicalized testing to find out what's happening, but he is not interested. He is on a team in town connected to a behavioral health team that just continues to support him, although he doesn't take any medication offered and doesn't want any testing, but they continue to support him. So I think it's, it can happen, and there's like different levels of that where there's some acceptance of some medications and maybe some acceptance of a preventative health screening, and so you have the knowledge and then you can decide what to do with it. So we will meet people where they're at.
How about the concept of isolation being a number one health risk in terms of maybe people having more suicidal ideation and people who are isolated?
Isolation and loneliness.
Ministry of, it's in the UK, they have a Ministry of Loneliness. It's connected with geriatric services, but they go to visit people. They say this is a health risk and we're going to address it.
I love that. I definitely think I'm interested to read more about it, but I would suggest that is definitely linked to more behavioral health concerns and less willingness or access to care and motivation to do something about it.
Are you ever called upon to do public education, like speak at a forum or a church, or saying this is what our community looks like and needs?
I feel like no. It's been more of just telling people about the program at this point. Yeah.
I've got a question. So we've talked about a lot of heavy stuff today, so we can maybe lighten it up a little bit. What do you do for self-care? I mean, you see a lot of folks in the community, a lot of different personalities.
Yeah.
So I'm sure it could be stressful at times.
Yeah. Some days are heavy.
Mm-hmm.
For sure. I love to move my body. I love exercise. Running has been a really helpful thing, and swimming has been two things I go to for myself. And then I have 2 kids. And my kids re-energize me.
Yeah.
People have said before, like, you need to do self-care like a massage, although this massage thing looks very good right here. But I find that those things are helpful for me, but I really like spending time with my kids, and that re-energizes me and my husband. Yoga, time in nature. I'm a hiker.
Okay.
A fun fact, my husband and I hiked the Appalachian Trail back in 2010.
The whole thing?
We did the whole thing with our dog.
How long did it take you?
6 months.
Wow.
Yeah.
Just one shot, 6 months.
Yeah, we did one shot with some side trips and some hitchhiking and some, navigation of things.
Did you Uber at all?
No Ubering
No
then.
Ubering,
And we had a flip phone.
Okay.
So, we was only used for emergencies.
Wow.
So, back in the day.
That sounds really peaceful.
Yeah. So, I feel like my nature is my go-to
That's great.
for self-care.
I used to work at an outdoor rehab called Four Circles.
Huh.
And it was I enjoyed being there because I got to go to the woods and play every week, and I got paid for it. Not play, but you had to take care of 15 people, but
Yeah.
it still beats the alternative of a cubicle.
One of the things I love about our mobile team is that I'm outside.
Yeah.
I have the option of being outside. I can open the door, and in the office space, I found myself, you go room to room to room,
Uh-huh.
and it's just the nature of it, but I was like always yearning to be outside, and I loved seeing people in our parking lot. That would happen sometimes at the old Asheville Center, someone that really would benefit from community medicine, mobile health, didn't want to come in, and so we would sit out on the curb and meet them where they were at.
Mm-hmm.
And that was always my favorite interaction that I had.
Any other questions?
Not that was the last one I was trying to say
That was
at
a
the
good one.
end. Yeah.
I felt like I was digging a pit for myself. I'm just going down this academic, sinkhole. What if? Here's a what if, and this is a big umbrella question about, and again, not representing any particular, not a company view or politics, but what about policies? Would you want to change if you could change something in the system, policy-wise? Where would you start? Even where would you start at? I don't know.
Yeah, where do I start? That's a good question.
Okay. Marinate a little bit.
Let me marinate on that one. Yeah, I mean, the first thing that really popped into my head was, better access to insurance.
Uh-huh.
Because of the things that come about every day for me and the patients, and co-pays and availability of services that people want to have and are wanting to access but are unable to access because of payment.
And because you're a prescriber, I mean, you got to stay on top of all the pharmacy stuff too, on top of everything else, right?
Yeah.
Jeez Louise. How do you find yourself advocating for your patients within a somewhat tangled system?
I feel like that's a big question.
I mean, you're
too.
there for them. Physically,
Yeah.
You're there. I show
Right.
up in my van every
Sure.
week. Okay.
Sure. I'm physically there. After they leave, there's still a lot of advocating that happens with community partners, with getting appointments, with following up if they miss an appointment, at the pharmacy level, if a prescription is lost or stolen or, whatever,
Sure.
then communicating with the pharmacy, hey, I allow someone to pick this up. So there's a lot that goes on after the patient leaves. Connecting them to services like y'all, getting them to spaces that are safe, sending referrals to places like Haywood Respite or the Sunrise Respite. Is it called Sunrise Respite?
Blair H. Clark.
Blair H. Clark. Yeah, the Blair H. Clark. So a lot of that footwork that happens after the patient leaves.
What was your motivation for doing all this? I mean, somewhere back in your educatable days, you said, I want to do this. What prompted you to want to do this?
Specifically community medicine.
Yeah.
I think I got the taste for it when I first started at Appalachian Mountain. In going to the rescue mission and going to some of the smaller clinics that no longer exist. So one of them was near the Vanderbilt apartments, and one of them was actually in the basement of South French Broad Aston Towers. We had a small clinic there, and it was me and another woman that I was training with at the time, and there was a great need there, but it didn't feel like the right place or time. We didn't have the support at the time. But I remember thinking oh, I love this. This is fun. This is different, and I'm meeting people where they're at, and I felt like the connection with a patient was really different than in the office.
Okay.
And I found myself going on foot often from the rescue mission and seeing people in the parking lot or at Haywood Respite, or they didn't want to come into the rescue mission for some reason. And so I'd like meet them outside, and the rescue mission staff were always very good about saying, hey, someone's here to see you, but they don't want to come in for whatever reason. They would come and get me, and I would see them out in the gravel parking lot. And so I think from there, this idea like grew for more mobile medicine, and then COVID hit, and there were some great advocates for community medicine and mobile medicine, like Jim Hardy.
Oh yeah.
Like Dr. Crane, Dr. Dowling was always there. Jacqueline Bandel, who was a NP with us for a long time and huge in community medicine.
She got her doctorate.
Yep. Those were all the seed planters.
That's what I realized NPs can be PhDs. I'm like, oh, okay, that makes sense to me.
Yeah.
We're close to the end here.
We are? How much time we got?
Well,
Ish.
5 minutes.
It does go very fast.
It does.
So fun to chat with you.
Oh, well, good. He's more fun than I am.
No, not really.
Somebody wants to be an NP or
Yes.
do community health. What traits or skills? You said, here's what you should be growing and working on right now.
Oh, that's great. Great question. I think in community medicine, you have to be really versatile, very flexible, ability to adapt to the situation, to work in different weather, especially with mobile. Yes. Have some gear. Pack your lunch.
And snacks.
Bring a water bottle.
All that hiking on the trail prepared you for this job.
Yes, it did, actually. I think it might have. I think all of those things are the personality traits, ability to work with a team, ability to collaborate with others. It's really like a non-competitive vibe. You have to be able to collaborate. I've got to be able to, I need to work with Mayhack. I need to work with Minnie Jones. It's not a competitive, it's a collaborative vibe.
Think about working for an ACT team?
That's funny. We did have a program at one point that we partnered with ACT teams in town. ACT teams are so amazing.
They are.
Yes.
I was on 3 of them. That's the best peer support job I've ever had, except for the outdoor rehab job too. That was good for a different reason. Summer, thanks for taking even 45 minutes out of your super busy day. I know how you roll.
Yeah, thank you so much. I've
You're
enjoyed it.
welcome. I really enjoyed it. You guys are
Cool.
the best.
So just a quick announcement before we cut out. Every Tuesday here at the Drop-In Center, 209 Tunnel Road, Sunrise Drop-In Center, we have an in-person problem gambling support group. It'll be in the evening from 6 p.m. to 7 p.m. If you have been adversely affected in any way by problem gambling, whether personal experience or as someone who has been affected by a loved one or family or friend, please drop in and just see what we're about. We'd love to have you.
Love to see you here. Thank you very much.
Okay.
See you in a month.
In a month, yeah. See you next time.
Cool.